welcome everybody. For those who've just joined, my name's Alan Higgins. I'm the Health Equity Network lead. I'll just invite my colleague Jamaica to introduce yourself as well. Go ahead, Jamaica.
Hi everyone, great to see so many people on the call. I'm Jamaica, I'm the Health Equity Network coordinator.
And between us, we run the Health Equity Network. And our monthly webinars have become well established. We get good attendance. They seem to work very well. And we're particularly pleased today to have the theme on Marmot Places, Health Equity Marmot Places. And the way the webinars run is that we'll have presentations from three speakers who I'll introduce in just a moment. And if people can stay on mute during that time, that would be very helpful. There'll then be roughly half an hour to raise questions and make comments. If you would like, it's always very helpful if people raise questions in the chat. I'll then come back to you to come on screen and ask the question and make other points if you would like to do so. If you could stay on mute if you're not speaking, that's always helpful too. We do record the webinar and then edit it and post it on the Health Equity Network in the afternoon. If that's a problem for anyone, then please do get in touch and we'll see about what we can do about that. Just before anyone asks, we will make the slides available after the webinar so that you can make use of those too. So, with that said, we have three speakers today. So Michael Marmot, in a moment, will start us off with reflections on the state of health inequalities and work across the UK and internationally. Then Jessica Allen, who's the Deputy Director of IHE, will talk about the work, particularly in Marmot Places across the country and where IHE has been working in the past and will be working in the future. I'm delighted that we have Sarah Erskine, who's Head of Health Inequalities at Leeds City Council. And Sarah will talk specifically about the work that they've been doing in Leeds over the last couple of years. It's great work, very exciting work, and about developing, working towards becoming a Marmot city. So I hope that is of interest to everybody, and I will invite Sir Michael to get us going. Michael.
Thank you. I thought I'd give just a few seconds of background of how we got here. When I was pushing at WHO, we were doing this commission on social determinants of health. And the Associate Director General said, we used to think that aspects of society influenced health. We no longer think that. We think that health leads to the economy. We don't any longer think that social and economic conditions impact on health. That's where we were. We were pushing against this perception that if you try to unpick the relation between society and health, all you would end up with is that good health leads to economic growth. And that was the end of it. And so how do you get good health? You invest in health services. Nothing more to say. We have come such a long way since that position. It is vitally important, as we know, to invest in health services. That's not at issue. Our NHS is rightly valued and lamented, the current state lamented. But the idea that you have to act on society in order to improve health was an old idea that I was going to say got forgotten, I think got suppressed, but it's resurfaced. When the medical Royal Colleges all acknowledge this, almost all acknowledge this. I haven't got through to the surgeons yet, but many of the other medical Royal Colleges. When we've got authorities all over the place talking about health equity, avoidable health inequalities, and action on social determinants, wider determinants of health, we're making real progress. I was much influenced by a book that I read, I think at the end of 2023, called The Rise and Fall of the Neoliberal Order by American historian Gary Gerstle. And he used the phrase neoliberal order. He said the New Deal was ushered in by Franklin Delano Roosevelt in 1933. It lasted for just under 50 years till Margaret Thatcher in the UK, and Ronald Reagan in the US ushered in the neoliberal order. The foundation text for that was Friedrich Hayek, The Road to Serfdom. Our great colleague Joe Stiglitz, he and I, along with Monica Gaingos from Namibia, are co-chairing a high-level council on inequality, AIDS, and pandemics. Joe Stiglitz published The Road to Freedom last year. He said, let's take the idea of freedom back from the right-wing libertarians, back where it belongs. How do we create lives of dignity for people? How do we create lives, and now I'm quoting Amartya Sen, that give people the freedom to lead lives they have reason to value? Social determinants of health is very much devoted to creating the conditions for people to have flourishing lives, lives of dignity, lives that give people the freedom they have reason to value. That idea didn't get taken up enthusiastically by the government that was elected in 2010. I'm being subtle here. It was actively rejected. I commented to Alan that I seem to be approached by civil servants from all over the place at the moment. There were a dozen years where nobody in government wanted to talk to me, not in the civil service or government. Now they do. So we had a 14-year period where life expectancy did not improve at all, where inequalities got bigger and health for the poorest people got worse. And that was the context. So what are we supposed to do? Sit on our hands and wait for something to change, for neoliberalism to run its natural course and get replaced by something? Well, people in Coventry said, we're not going to do that. We're not going to sit on our hands. We want to take action on the Marmot principles that we laid out in our 2010 review, Fair Society, Healthy Lives. When I go to Coventry now in 2025, the level of enthusiasm in the room is palpable. They started this journey in 2013. 12 years later, the new chief executive of Coventry said, we're going to renew our Marmot activities. It's palpable, so enthusiastic. Then Greater Manchester picked it up, said, we'll do it. The pandemic happened. I went to the National Theatre and saw Dear England, and I'd quite forgotten when they put up England 2, Germany 0. It brought back a memory. We published our 10-year on report on the 25th of February 2020, the day that it was England 2, Germany 0. The next day, the front page of The Guardian, the top 2/3 were England 2, Germany 0. The bottom third was jaw-dropping fall in life expectancy in the Northwest. So we got half the coverage on the front page of The Guardian of England, Germany. Right? That's not bad. But it was a statement that this was getting on the national agenda. And that was Greater Manchester. And now Jessica will talk about it. 50 Marmot Places. The Cabinet Secretary for Health in Wales announced publicly at a WHO meeting 3 weeks ago that he wants to make Wales a Marmot nation. We're working with Scotland. We've got a collaboration on health equity with Scotland, doing a national strategy for Scotland, 3 Scottish Marmot Places in Aberdeen City, South Lanarkshire, North Ayrshire. huge challenges. Somehow I feel if we can do it in North Ayrshire, we can do it anywhere. The challenges are enormous, but there's such enthusiasm. I was in Medway on Tuesday. I was in Liverpool yesterday, Newcastle a few weeks earlier. People are really enthusiastic about this agenda. You know, to have people fill a civic auditorium and they have to turn people away excited about health inequalities. What? Well, no, they're not excited about health inequalities. They're excited at the challenge to do something about health inequalities. So I'd like to think that our Marmot Places are actually important steps in creating the kind of society that we want, where all people can flourish and lead lives they have reason to value. And to achieve, that's our aim, to achieve that, we need some very practical steps. And I think, Jessica, you'll give us some insight into what those steps should be.
Yes.
Thank you very much, Michael. Go ahead, Jessica. Yeah.
Thank you, Michael. Jamaica, if you could load a few slides. Yes, I'm going to provide a bit more detail about what we understand to be the process and the impacts, most importantly, of our work with places. Next slide, please. So these are all our places. You'll see many more coming along in 2025, which is very encouraging. So this we're calling it a movement, and I really think it is a grassroots movement from local places, even without the national support that we know is so desperately needed on this agenda. Next slide, please. Some of the key points, perhaps, about Marmot Places. As we said, there's no requirement for places to take this forward. It's hugely challenging. They're very preoccupied, resources are short. So really quite extraordinary that they are proactively picking up this agenda and leading locally on this, despite the most difficult of circumstances and challenging of times. And we know that health, as Michael said, is deteriorating and health inequalities widening. So they are proactively approaching us to ask for support, advice, connection, knowledge exchange. And that's another point. Every place is different and unique. So although we have some general principles we work to, and I'll come on to those, we know that every place is different in all kinds of ways. The health inequality situation is different. The social determinants of health situation is different. The politics, the organisations, the challenges, etc. So we have to work with places to really identify the opportunities for action. It's usually been led by public health in local government. Once or twice we've had combined authorities, actually more than once or twice, probably 3 times, and also integrated care systems. But generally, I'd say public health in local authorities have been really picking up this agenda. Our work usually is quite intensive for 2 years and then more light touch after that. And we very much hope, and there's varying degrees of impact and success with this programme, of course, but we very much hope that the agenda stays in place for the long term, and you'll all be well aware that this is a long-term agenda that we're embarking on. So our intense involvement is usually 2 years. This slide, please, Jamaica. Features of Marmot Places, first of all, of course, they recognise that health and health inequalities are mostly shaped by the social determinants of health, and we spend a long time with places making the case. Obviously, public health usually recognises this, but it's also for other parts of the system. So we involve healthcare, businesses as much as we can, the economic sector, community and voluntary sector, making this case around their contributions to the social determinants of health. We do quite a lot of process of assessment, what's already happening, what the inequalities are, gathering qualitative information where we can, talking with stakeholder, identifying where we can go further. We think, push further on action to reduce inequalities. And at this point, there's quite a lot of evidence brought in from other places, and from the academic base. We evaluate how well the health equity system's working together, and that's a really important part of what you do. Yeah, usually at the end of this process, we have action plans, implementation. We hope, commitments from organisations across a range of sectors, and we very much begin to push forward on the implementation and making sure that the process is sustainable for the longer term. We're beginning to do a stock take of where we think we're having impact, and we see it in 3 areas. So first of all, action on those Marmot 8 principles. Secondly, what we're calling culture shifts, which is how the culture, we get health equity embedded across the system. So these are the 3 impacts that we're seeing. They're broad, they're broad. There's a lot that sits under these, of course, but the system change and culture shift, I think, is a really important and impactful part of what we've done. And then thirdly, what we're calling transformational processes. So these are the Marmot 8 principles, those key social determinants of health. Places usually prioritise 1, 2, 3 of those, but sometimes places ask us to cover all of those. This is the system change. So we look at the governance. How strong is governance across the whole place? Those governance systems for health equity. The leadership, really important, but how can we sustain leadership? It doesn't just rely on individual leaders. The advocacy within a place, these partnerships between all these partners, really important. Capacity building, making sure that health equity is embedded in all policies, and then getting community involvement, and we hope co-production in the design and delivery of the approaches. And then this part of what we're calling transformational process is a bit of a clunky phrase, but it's about trying to embed the approach in the processes and operations so that it's operationalized for the longer term. So for that, we talk about resource allocations. Are they proportionate to the scale of need? Are they universal? Yes. Are they proportionate to the scale of need? Are services similarly proportionate and universal? How much focus is on prevention and investing upstream? It's difficult to do, but we really try and push for that to happen. Can we strengthen accountability for health inequalities? Also a very important lever to get the kind of changes we want. Can we embed it in the contracts and the commissioning for health in a way that foregrounds health equity and the social determinants of health, kind of social value commissioning? And then finally, around monitoring and indicators. There are other ways in which this is done, and it's not always successful in every place to the same extent, but these are the way that we're beginning to see our impacts taken in the round from all those places. There have been a few, I think evaluation might be too grand a word, impact assessments of what's been happening in Coventry, Greater Manchester, and Luton. Specifically, they're available there. You can have access to them when the slides are circulated, also on our website. And then there have also been a couple of interesting articles on Marmot Places, the Local Government Association and the British Medical Journal. So you don't just have to take it from us. And we are producing a stock take overview, which I think will give some more information about what's been happening. But, as we've said, enormously encouraging that local places are doing this in this most difficult of challenging agenda, in the most difficult of times. And we really feel this is a grassroots movement that we very much hope will inform, and that the national system are listening and gathering the insights that we're finding. Thank you.
Thank you very much, Jessica. This is such a vast area of work that you've just covered, and great to see it covering so much of the UK as well. Thank you for that. Just to remind people, if you would like to post questions, comments in the chat, we will pick those up. But delighted that we have Sarah Erskine here from Leeds City Council.
Okay, so hi everyone. As Alan said, my name's Sarah Erskine. I'm Head of Health Inequalities at Leeds City Council. And I've been working on the Fairer, Healthier Leeds Marmot City programme for the last 2 years with 2 colleagues, Tim Fielding, who's our Deputy Director of Public Health, and Aisha Lewis, who's also on the call. So next slide, please. So we're at the end of our 2-year focus work with the IHE. So I'm just going to talk through that journey to become a Marmot Place, highlight some of the progress. It's been really brilliant, actually, being asked to do this, because it's always nice to take a bit of a stock take, isn't it? And it's quite heartening to see all the things we've done. So I hope you feel the same by the end of the presentation. And then I'll also talk about where we're going next. So this is what we set out to do in year one. We naively thought we'll do this in year one and then we'll move on and do all the other Marmot principles, but it won't surprise you when I say that actually going into year three, much of what's on this page, in fact, all of it remains our priority. There is a lot to do under the headings that we've got there. I just wanted to acknowledge, I don't know if Matt Ashton or anyone from Liverpool is on the call, but I shamelessly stole their phrase collective action because I thought it just really encapsulated what we need to do in terms of partnerships and really get cracking with addressing health inequalities. So thank you to Liverpool for that. Next slide, please. So we now have our Fairer, Healthier Leeds whole system review report and 15 high-level system recommendations. We've also got data packs and recommendations for 0 to 5-year-olds and housing. So we've got a set of recommendations that are driving action across culture, policy, programmes and services. So kind of really picking up on some of the things that Jessica was saying. We were challenged quite early on, and I think probably lots of areas will also experience this almost on day 2. What have you done? How have you solved health inequalities? What are you delivering through the Marmot City programme? So it has been really important to us for the kind of validity of the programme, also for people in Leeds, for us to get cracking and do some things. So we have delivered work and impact at kind of programme and service level. But the transformational bit for us really has been around culture and been around kind of how we influence the citywide culture, but how we also work across culture. So we've really built really brilliant relationships with asset management and regeneration, with housing, with the economic development, relationships that we didn't have before. And those relationships, that understanding of culture, is really helping us drive policy, new policy at a local level. And we talk about policy as being like the engine room of this work. So next slide, please. So in our Fairer, Healthier Leeds report, we've got, I think it's 15. There are a lot of 15s in our work. I've realised whole system recommendations. Some of the things that we've done to get cracking really in delivering those are listed on that slide. We've got really good engagement and alignment with our Best City ambition, which is our kind of super strategy, which covers inclusive growth, health and wellbeing strategy, and our carbon zero, net zero work. So much so that the Best City ambition kind of machinery has adopted the Marmot City indicators as the scorecard for the city, which, you know, that was never on the cards when we started this work 2 years ago. There's lots of things I could talk about there. Just to highlight, we've got a social determinant template in primary care. This is something that a colleague in another part of the Public Health Directorate really ran with. So this is around enabling GPs to have non-stigmatising conversations with people about the rest of their lives, and within 3 clicks be able to refer them to really appropriate services. We've moved I don't know if you can remember the infographic I showed at the start. We had a cross-cutting theme around racism and discrimination. We're taking that on into a very specific piece of work now in the 3rd year, 2nd to 3rd year, looking at structural racism and discrimination. Huge amount of work involved in that, which I can answer questions about, but I haven't perhaps got time to go into in detail. And then next slide, please. One of the really exciting things that I'm really just very passionate about is really working with asset management and regeneration on a health in all policies approach. So we've got some levelling up money in the city to work in Holbeck, which is one of the most deprived neighbourhoods in Leeds. It has some of the poorest outcomes for women in the city and nationally. So lots and lots of challenges in that area. Asset management and regeneration are doing a project which is improving the public realm, community asset transfer and housing retrofit. And we are working alongside them with the recently refreshed OHID Health Equity Assessment tool to really embed equity as we go through that process and really kind of centre everything that the regeneration team are doing as having a health outcome, and thinking about how are we designing healthy places and how do we make sure we're not inadvertently widening health inequalities. So next slide, please. So one of the priorities was the 0 to 5 work. We have honestly struggled, I think, to make as much progress with this as we wanted. It's a very busy part of the system, and I'm sure other people will know on the call, excuse me, that children's services have been under huge amounts of pressure financially and just in terms of the need in the system. So We have made perhaps less progress in some ways than we would have liked, but there was a lot of really good work also happening in Leeds. What has happened is the Marmot work has galvanised different bits of the system to work together. So we used to have a Best Start programme, which was 0 to 2s, and then an early years programme, which was 3 to 5s. Those have come together now. And the Marmot recommendations and the prompts and the what are you doing about this questions that Tammy has been asking the system, they're informing how that work develops. So we now have a 0 to 5 and housing strand of work that's happening, and much more focus, I think, front and centre on the relationship between deprivation and ethnicity and childhood educational outcomes in particular. So next slide. Thanks, Ellen. So housing, there was stuff starting to happen in Leeds on housing already. We've, in terms of kind of the Marmot work, really kind of supported that work and also developed new things. So we've got, we commissioned an evaluation of our existing selective licensing scheme, a kind of quick summary evaluation, trying to capture some of the health impacts of a scheme that was going. That evaluation and some future kind of costed health benefits work that I'm involved with, that's going to inform the business case to extend selective licensing around the city. We've put in a lot of capacity around kind of bringing health and selective licensing together at an operational and strategic level. We've developed a tool using regional, actual and modelled health data and aligning that with GP QOF data, not individual linked data, but at LSOA level. So we can very quickly move money and funding to the right place in the city, depending on health need, depending on housing tenure. And all of that work has provided a basis really for a piece of work nationally, which we're hoping to be involved with the Health Foundation around linked health data and housing and the impact of selective licensing. And then we have set off through the Health and Housing Group. They wanted to focus on 2 key recommendations from the Marmot work to start with. So we've got some new work looking at refugee and asylum seeker populations and their housing needs, and gypsy and traveller communities as well. Very different communities, obviously very acute needs. So we're excited about that, and there's some kind of clear ways forward, I think, starting to emerge. And then something else which came up again and again around health and housing was mental health. So the mental health of housing workers, the unmet mental health need of people in inadequate housing. So housing and mental health are obviously 2 huge areas, but we're starting to develop some work, kind of strategic work, but also operational work to bring those 2 bits of the system together. Next slide, thanks. So we have 15 Marmot indicators, and if you are interested in sort of understanding the process that we went through to choose those indicators, then there's a narrative on the IHE website. We have 15 at the moment. We're working through some data quality issues. We may end up with 13 or 14. But what we really wanted to do with this work was present the slope. So in Leeds, we historically were presenting deprived and non-deprived Leeds, which is a terrible phrase. Or we would look at ward data, or little bits of the different parts of public health would look at decile data for a particular outcome indicator. But what we wanted to do with these kind of super indicators, which are sitting with the best city ambition, is have a really clear way of looking at the slope of inequality in the city. And I can't tell you, I can't quite explain how transformational that orange line has been. There's no arguing with that graph in terms of the relationship between deprivation, social, educational and health outcomes, depending on what indicator you're looking at. So we are, as a kind of approach, always looking at IMD decile and then ethnicity where possible. And yeah, so we're using that to really kind of galvanise the system and galvanise the best city ambition to really focus on inequality. Next slide, please. So looking ahead, the small matter of delivering all the 40 recommendations that we have in the system, embedding a health equity approach as the way that we do things and being clear what this means for people and organisations. So again, building on what Jessica said, people want to know now, commissioners want to know what tell us what to do. So it's about us kind of operationalising and making tools available for people. So that might be the health equity assessment tool, it might be commissioning for racial health equity. So we're really working on making kind of products and systems and policies really, really simple for people with different partners in the system. We've got our year 2 event in July, and then we are ensuring our approach is aligned with all the different things that are happening in Leeds and also nationally. Obviously, the new work and health agenda, focus on neighbourhood health as well. So constantly trying to make sure that we're staying relevant and keeping a focus on health inequalities where perhaps things might drift a little bit. And one more slide, I think, from me. Oh no, 2 more slides. So the other bit around kind of embedding equity and developing a kind of movement, which I know that you've talked about, Jessica, as well. What we want to do in Leeds is not just have it so that public health are leading this work, but so that the partners in the Marmot Partnership are able to advocate for this work more broadly. So we've got a communications toolkit. We've also got an interactive engagement pack, which we're using with different services and different bits of the system. So what does health equity mean for a one-stop shop or someone working in a library? How do we do things better? So we've got a whole suite of resources on that. And my final slide, Alan, please. So just some reflections. It's been really important to translate the Marmot 8 principles and the Marmot approach into our local context, and to be quite agile with that, to make sure that we are kind of staying relevant and people can see the value and the resonance of the Marmot work. That central point, super important. I can't kind of stress that enough. Working across cultures, across public health and economic development, you know, working to kind of build a common language and build relationships, absolutely central to being able to deliver this work. And then I guess just picking up what I said before, that kind of disaggregation of the data and constantly looking at the slope is really transformational. So Tammy Boyce, who works at the IHE, has been working with us. She has done a really brilliant piece of work, thank you Tammy, capturing some of the changes that have happened, the softer changes or the attitudinal changes that have happened with partners, and doing some interviews. And I just lifted one of the quotes from that report, which is, we all get health equity now, we all get how important social determinants are. So that's where we are going into year 3. I think we've got a real groundswell of positivity, actually, again, despite the really difficult climate. And then we've got some really practical and tangible things to show that people can kind of really see that there is a possibility to make a difference, even if things nationally and internationally are quite difficult. Thanks, Alan.
That is wonderful. That's such a good presentation, Sarah. Nothing beats hearing from people putting the Marmot principles into practice, and you've delivered that so enthusiastically in that short space of time there. Their work is really seriously impressive. And myself and Michael were in Liverpool yesterday at the launch of Liverpool as a Marmot city, and if no one else has responded, I think we can be delighted on their behalf that you use the term collective action. That's all about what the network is for sharing those ideas. So while I catch up with the chat to see if anyone has posted questions, you can raise your hand using the hand facility there. But we had a question early on from Sylvia de Souza. Sylvia, are you able to come online and ask that really interesting question about community voluntary sector?
It is a bit busy in the office, so I would rather not.
That's okay. Yeah. Go ahead. I can read your question for you if you would like, if that would be preferable. So let me just, oh, there's quite a few questions there. Let me just find my way to Sylvia's question. And it was about whether, I think it's a question initially for Jessica, but then others can join in, is whether a community voluntary sector could define or initiate progress towards a Marmot Place.
It hasn't happened, well, let me rephrase that. In terms of being a Marmot Place, we always very much involve the community and voluntary sector so that they are seen as core partners in this work, representing disadvantaged groups, providing services often, and their views are, you know, really important and taken on board, I think, and was absolutely a core partner. In terms of initiating, no community voluntary sector has initiated a Marmot Place, but we have worked with national voluntary sector organisations who have then worked with us locally So we've got a programme with Bernardo's working with 3 integrated care systems to deliver programmes on the social determinants of health for children and young people. So we very much see the community voluntary sector as absolutely central to this agenda. Just in relation to Marmot Places, haven't initiated it. Does that answer the question?
I think it certainly goes a long way to answering that question. Please do come back on and elaborate on that. Rather than go to Michael or Sarah on that yet, I'm going to add to that, Jessica, because there's been a couple of questions here about Marmot Places and rural areas. And I'm going to go to, and apologies, I can't see your first name, Mackley Ward, H. Mackley Ward, it just comes up on mine. Would you like to come on screen and ask your question about about rural areas?
Hi, I'm
ahead.
also, it's also not ideal. I'm having a smart meter fitted, so there may be drilling. But I was wondering if the model is applicable to rural areas, particularly when you consider the amount of hidden deprivation that you can find there. If all, sorry, I'm just remembering back, if all of the Marmot Places are cities within that question. Thank you.
Shall I jump in? Yeah. Yes, we're working with rural areas. They're not all cities, and interestingly, we're increasingly working with rural places. And you're absolutely right, the deprivation and the inequalities are very much hidden there. So we're doing a job now to understand how we can sort of surface those inequalities in a way that's recognised, so that they can be tackled. And it's difficult when the data's at a level where they're hidden. So that is a big piece of work across a few places that we're working with now. I hope to be working with Isle of Man coming up as well, and they've got similar issues with as an island, that their inequalities are hidden as well. And across Scotland, that's very much at the forefront of people's minds as well.
And to come in Oxfordshire, where we're working, they said very much from the start, we don't want you to focus on Oxford, we want you to focus on rural poverty. And in fact, the leader of Oxford County Council said she comes from beautiful Chipping Norton, gateway to the Cotswolds and everything. But even within Chipping Norton, and certainly in the rural areas, there's deep pockets of poverty. We used to talk about Marmot cities. Jessica said, no, we should talk about Marmot Places. In Gwent, Torven, you wouldn't call it a city. It's a small post-mining community with a big rural, in the middle of a rural area. So we're working in places at very different scales, and rural deprivation is a relatively new focus for us.
Thanks, Michael. Thanks, Jessica. Lucy Price, this is a question specifically for you, Sarah Erskine. If Lucy, do you want to come on?
Yes, thank you. So my question was, we're working in Oxfordshire to come on Marmot Place, and it was just about how you've kind of involved partners and teams internally within your council in Leeds, just as some shared learning.
Yeah, hi Lucy. So I realised I didn't cover the governance bit of the programme, which might have been helpful. So we have a Marmot Strategic Delivery Partnership. We love long titles in Leeds. So the Marmot Partnership is a multi-sectoral partnership where, well, for the last 2 years, we've really been focused on kind of developing the reports, and really focusing on a couple of the projects that I outlined today. I think it has been, what we've recognised in the first kind of 18 months, that a lot of our work was outwards from public health. So, sorry, are you public health, Lucy?
Yes, but I was just thinking about like internally other departments within the council.
Yeah. So, and I think someone else has asked that question as well. So I actually can't quite put my finger on what it is that's enabled us to develop those relationships. I think with asset management and regeneration, I think regeneration colleagues are kindred spirits, actually, for public health. And there's someone in Leeds who talks very much about regeneration having the same roots as public health hundreds of years ago. So I'd advise people to go and find asset management and regeneration or regeneration colleagues, because I think they're just waiting. And those teams in Leeds have said things like, it's enabled us to give a new focus for our work or a new language to describe what we're doing. It's helped us reframe everything around health and wellbeing. So that's good. Economic development housing, I think there was a longer journey to go on. I'm really not sure what it was. I think for economic development, I think we had a project to work on together, which was Good Jobs, Better Health, Fairer Futures, which is a Health Foundation funded project. And I think through that, we developed some brilliant work and some brilliant relationships. Yeah, I'm not entirely sure. I think let me think about it and come back to you. But I think it's taken a long time and it's taken huge amounts of resilience. And I didn't talk about any of the challenges in that presentation, but there have been many bumps in the road, and we've made lots of missteps in kind of developing relationships. But we've always had, I suppose, very strong senior strategic leadership. So the Marmot work was happening anyway. We just had to keep going, I think, maybe in hope that people caught up with us. So, but I'll have a think about what the actual element was that helped us develop that relationship a bit more.
Excellent. Thank you very much, Sarah, and thanks, Lucy, for the question. I'll come back to some more questions about Leeds, Sarah, to keep you on your toes. But first of all, we'll go to the people who've raised their hands. So, Barbara Gray, would you like to come on and ask the question?
Hello. I mean, thank you very much for putting on this event, and great to hear from you personally, Professor Marmot. And yeah, I've been a long supporter of the Marmot principles for at least, 10 years. And my background is economic development and local authority, interestingly enough, but I've since set up a Black-led infrastructure organisation to support the growth of the Black third sector in response to Marmot. And we're in a borough where there is a large Black population for England, and there's lots, and we use kind of an asset-based approach to kind of drive it from the community themselves, because there's long histories of relationships. And that's actually, it's really interesting when I hear these conversations to realise just what we've been able to achieve from that perspective, and it's about enabling the communities. And I just wondered how that might have been considered or embraced about enabling the communities to drive the change themselves, and working with statutory agencies and direct leaders of services.
Who would like to begin?
Yeah, shall I come in? So reflecting yesterday's experience in Liverpool, and we had reports from 4 case studies that or 3 of which bubbled up from the community. One of them, the first one, was about recruiting large numbers of volunteers from the community to improve neighbourhoods. And what was inspiring, it was all inspiring, but particularly inspiring about it was not just did they have indicators of success in the community, the positive impact it had on the volunteers. It improved their lives. So, and it comes back to the earlier question about the voluntary and community sector. They may not have initiated becoming a Marmot Place, but the voluntary and community sector has played a vital role. And just because Liverpool's on my mind as I was there yesterday, Citizens Advice Bureau in Liverpool, I think somebody put in the chat the citizens' advice on prescription. GPs write prescriptions for people to go to citizens' advice, and they're very active, reducing poverty, improving mental health, extremely important. And to come back, Barbara, to what you said about the Black community, we were rightly criticized. I mean, I'd plead mitigation with our 2010 report because we didn't say enough about different ethnic groups. We didn't really tackle the issue of racism. We did a bit more in our 2020 report, but the data just weren't strong. And we published a report commissioned by London on structural racism, ethnicity, and health. So then we came right out and said it. Racism damages health directly. Second, we said racism leads to an adverse distribution of the social determinants of health, housing, poverty, and the like. And thirdly, we said racism leads to poor services. And we were quite open and explicit that we've got to take this into account alongside our long-standing preoccupation with social determinants of health.
Thank you very much, Michael. If there's nothing further to add, we'll move on to another question from the hands up. Amanda Wright, would you like to come on? Thanks, Mike.
Hi, yes, sorry, my comment related really to something that we were talking about earlier around the role of the voluntary sector in Marmot Places and linking in with rurality, because those are two particular areas of interest from where I'm sitting at the moment. And I was asking in the question and answer section about particular challenges and benefits that anybody that had been involved in Marmot Places in rural areas had come across, just with the thought of that challenge of rurality that does sit across so many things.
Jessica, would you like to pick up?
Yeah, well, I can respond, but I also wondered if maybe Mark Whitmore from Kings Lynn, West Norfolk, who's thinking exactly about that, would like to reflect on the question and the community and voluntary sector, or somebody from Oxfordshire as well. It's absolutely right. It's a key question. And honestly, community and voluntary sector organisations are propping up rural areas to a huge extent, partly because the inequalities are unsurfaced, and or they're too far away. The services, the help and support that's on offer is just absent there. But I'll hand to Mark, because I think, Mark, you have some good insights.
Nothing like being put on the spot, Jess. No, that's absolutely fine. Thanks.
Sorry, Mark.
That's okay. That's okay. So just on a couple of things. Yeah, so I'm from West Norfolk, Borough Council of Kings Lynn and West Norfolk, and I think there was a question earlier actually about, is it always public health that lead on that? And in West Norfolk, it's not, because it's me and I'm not a public health professional. I am an environmental health officer, but not a public health professional. So, and that was a very conscious decision here in Norfolk, just because we're a two-tier area, that the Borough Council would lead on it. So I have that privilege, and it's been very enjoyable so far. In terms of rurality, yeah, I mean, we're a 550 square mile borough. So we're pretty big as districts go anyway, and the vast majority of our residents live outside of our three main towns of Hunstanton, Kings Lynn and Downham Market. But our deprivation indicators are mainly in Kings Lynn. We've got a significant amount of deprivation in Kings Lynn. The data therefore tells us concentrate on Kings Lynn, because that's where all the deprivation is. And the real challenge is actually, we know that that's quite it's a bit of a blunt instrument in terms of rurality. You don't get it, you don't measure it. So we're really keen to understand the impacts. We've got a really good, we have what's known as the health and wellbeing partnerships in Norfolk. There are 7 across the district boundaries, which are looking at the more wider determinants of health that place boards and others might not necessarily have the time or space to deliver on. And our partnership comprises predominantly of people from voluntary sector, ICB obviously, and ourselves and Public Health attend, but that, you know, we've got a really powerful public sector voice in that area. The real challenge is that there are so many individual groups, large and small, working across those areas that it's almost impossible to find everybody. So we're working on that challenge at the moment. I had a very productive conversation with Alan yesterday around how we might use the Health Equity Network to build a community of interest in West Norfolk that allows some two-way conversation. Sorry, Alan, if I've put you on the spot around that, but I think that's you know, that is the real challenge. How do we hear those voices? And I think data is really challenging around that. So we need to understand the lived experience more. So that's where we are, but I wouldn't say necessarily I've got an answer on it at the moment, just that we know that it's a significant challenge for us.
Excellent. Thank you very much, Mark, for coming on. That was really helpful. Jonathan Townsend, you posted a really interesting question in the Q&A. Are you able to come on and ask it again?
Yeah, sure. Thank you, Alan. I guess my question and observation, I mean, I'm really enthused about the Marmot work, particularly now that Newcastle signed up to become a Marmot Place. But I get the feeling that people on this kind of call inherently get the benefits of this sort of stuff. And I'm kind of wondering, is there any work across the Marmot Places to take a look at the wider impact on local communities in terms of economy, culture, health and well-being, but also criminal justice and antisocial behaviour? My gut sort of says to me that if we get health and well-being sorted, those other things will start to kind of rise as well. So I'm kind of interested in that wider impact, particularly about how we might use that to be able to engage other local authority departments and partners that maybe don't necessarily kind of see themselves as traditionally part of the health agenda.
Thank you.
I mean, if I can jump in, I think you've raised a very important issue. I can point to spots, for example, taking action on trying to reduce the proportion of young people not in education, employment, education or training, not only has led to a reduction in NEET, it's led to a reduction in civil unrest and disorderly behavior in young people. It's common sense, but it works. So there's real benefit from it. In terms of, you know, we know the correlation, not causation, but we know the reduction in spend on services for young people correlated with a rise in disorder, social disorder in young people. So there's likely to be all kinds of benefits. I think, Alan, we have to stop in a moment, but before we do, we didn't rehearse this together with Sarah. So my pleasure at what Sarah had to say was totally spontaneous. And we put a lot of effort into putting indicators in place for evaluation. What it doesn't measure is Sarah's enthusiasm, her enthusiasm for what they're doing. And you know, we just kicked it off in Newcastle, but that same kind of enthusiasm in Newcastle, or that I got in Liverpool yesterday, I mean, Sarah's an inspiration. She says, we're doing this and we're all so excited about it. It's making a difference. And a particular pleasure for me was the fact that the gradient you found transformational, showing that line is transformational. I've been singing this song for 40 years. So to hear that you're making a difference with it, thank you. You've made my Thursday. You've made my week.
I'm going to squeeze in one last question, and it's for Sarah from Crawford McGuigan. And can you come on, Crawford?
Thanks, Alan. Yes, Sarah, I liked the comment that you made there about keeping the slope visible, the health inequality slope, and Sir Michael there's mentioned that as well. what impact did you use that slope with communities directly, and did that forge action from and within communities?
Not yet. So those indicators and that slope is kind of part of the kind of strategic conversation about landing a better focus. I think almost I think, well, this is what I truly think. This might not be the right thing to say, but I think sometimes we think that health inequalities can't be changed. But I think when you have something like that, the health equity, that orange line, the transformational orange line, and the health equity focus, that really galvanizes people, I think, at a strategic level to think actually we can do something about this. The community involvement question and how we work with communities is a very particular piece, and I know Barbara, you talked about that as well. We're working with the Poverty Truth Commission, we're working closely with the third sector on our partnership, but also through some of the structural racism work as well. I must say, in Leeds, people in the third sector and a lot of communities, they don't want any more reports, thank you very much, or any more graphs. They just want stuff to crack, you know, we just need to get on. So it's that constant balance of being able to make the case at a strategic level, people who've got the money, and then just being able to work in a collective way and deliver some action. I just wanted to come back to the question that I answered before. Sorry, I know we're going over slightly. And I think actually something that's really worked for us is just being quite belligerent with our messaging. And we've taken some of the Health Foundation frameworks messaging. So everywhere we go, we say that people are dying earlier than they should. It's not to do with your GP, it's to do with the building blocks of health, and these are amenable to change. It's like the thing that we say before we say anything else, before anywhere we go. And that, I think, is a really useful kind of just piece of messaging that if you say it often enough, people start to think, actually, health is why we're here. We're not here in a local authority to build boats, are we? Well, we might be. But you know, what we're here for is people and people's health. So, yeah, I just wanted to say that messaging is really important.
Excellent. Thank you very much, Sarah. That we are out of time, but thank you so much, Sarah, for your enthusiasm and frontline experience. That's been really helpful. Thank you to Michael for that oversight at the beginning, and for Jessica for giving us that view across the whole of the UK. Do join us again in a month's time when we have one of those special webinars where we invite people who are network members to present, and we have 3 great presentations coming up in a month's time. Thank you so much for today's webinar. Thank you for attending. Thanks for the questions and for the presentations. Hopefully see you in a month's time. Thanks very much.